And good morning and welcome to our Adolescent Health Initiative New Mexico session this morning. And thanks for joining us. We have a good crowd today in the room as well as out there in cyberspace, if that's still a term. So I just wanted to remind you all, we are recording the session this morning. So please, during any discussion, do not include any health information, personal health information. If you do need to mute or unmute yourself, we would love to have you as part of the conversation. We do have a good sized crowd, but there should be time for some discussion and questions. So verbal is always better, but you can always use the chat box as well. And if you do wish to receive CME or CEU credits, an attendance certificate, then we do need you to announce your name either verbally by unmuting at the bottom left of your screen in the Zoom window there, or you can always use the chat box in lieu of that. Once again, there's your icons for starting up your video in case you're not already on video. And it looks like we're a little bit shy this morning. That's all right, it's 8 o'clock. As soon as you're ready, go ahead and click on that. And we'd love to see your faces. There's our disclosure and accreditation statements. We're required to post those in order to offer you the CMEs. And a big part of our Adolescent Health Initiative New Mexico program, our initiative here, in order to give out our certificates, we do have case consultations. You can be reimbursed as the provider from Molina Healthcare or Blue Cross Blue Shield. So if your patient that you bring to us is with one of those entities, then you can bill them for up to $150 from Molina, and I believe it is still about $75 from Blue Cross Blue Shield Centennial Care. So take advantage of that. It is not as utilized as we would hope, but it's a really great service, and you might as well go ahead and bill for that. We do have our asynchronous online learning platform as well, called Moodle. That is through the HSC here. Anyone is able to access those for CME credit as well. Any of the sessions that we've had over the course of this past year, you're able to log in and get half a CME for each one of those. You do have to take a very short test at the end, typically 4 to 6 questions. But once you do that, you'll get credit the month following. So go to our website, that's at envisionnm.unm.edu, and click on online training and fill out the form there, select AHI New Mexico, and click submit, and you'll be receiving an email from Michelle Widener or myself. And at this point, we would love to have you let us know that you're out there and where you're from. So just announce your name, either verbally or through the chat box. Looks like a few of us already have. And anybody out there on audio? All right, we do have quite a few people chatting in. So at this point, I'll go ahead and hand it over to Jeannie Dalen, our facilitator.
Good morning, everyone. Jeannie Dalen, clinical psychologist, assistant professor at the Department of Pediatrics. This morning is our last session of the Adolescent Health Initiative New Mexico, and I believe that we are ending on a bang. We have a great topic for you guys this morning, and from everyone out there signed up, you can see this is a highly relevant topic. This actually came up in one of our case consultations a couple weeks ago. So what we'll do, we'll get started right away. We'll go ahead and go around the room in the Envision Studios to see.
It doesn't affect the volume.
This morning. Hi, is someone coming in on audio?
Hello there, can you hear me?
We can.
I actually have the computer screen up, but I cannot make the volume come up. So now I've unmuted, but I still can just very barely hear you.
Is this Colette?
Yes, it is.
Okay. Colette, perhaps Kevin can help through, you two can chat through the chat box to see if we can figure out what's going on.
Okay, and I don't even have access to the chat box anymore. Let's see if I can get it here. Oh, there it is. Okay.
No.
I'm trying.
No
Trying to see
problem.
what we were talking about yesterday.
The fun part of telehealth and cyberspace, right, everyone? So we will go around introduce those of us in the Envision Studios this morning, and then I will introduce our speaker and get started.
Andrea Anderson, QI Specialist here at Envision.
Kristen Bennett, pediatric dietitian in Vision.
Ashley Davis, pediatric resident. Neil Mascareñas, also a pediatric resident.
Excellent. So with that, I'd like to introduce us to this morning's topic. Go ahead. I'm sorry, does she have the?
Oh.
Yeah. She's here, title selected. There we go. Excellent. So I'd like to introduce us to everyone to Lindsay Smart, who is an assistant professor in the Department of Psychiatry and Behavioral Sciences, and she is also director of the Early First Episode Clinic and Consultation Services. So with that, this morning she's going to be talking about early screening and identification of psychosis in youth. So with that, I'll turn it over to Lindsay, and she's let us know that she would welcome questions or comments throughout.
All righty. Well, thank you. I'm very happy that there are so many folks on this webinar today, especially I have a little bit of a list. There's a wide range across New Mexico. One of the big initiatives that we have with the early first episode psychosis is really to expand knowledge about screening for psychosis and across New Mexico, but even better across the United States. We've got some folks possibly from Puerto Rico. So this initiative is one that I have grown into, and it was one of those ones where a lot of folks, you go to graduate school and they sort of talk about difficult things that you might see when you are in your clinical service. And then they sort of move on through a variety of topics. And the psychosis was one that in my graduate training was touched on, and I went to a very child-specific program. But not a lot of time was spent really trying to understand what that could actually look like, and what would I see, and what would I do with that if I saw that. And I think that as I've been working in the first episode and early psychosis area, only for about maybe like 3 or 4 or 5 years, there's just been an explosion of research that has come out about the importance of early identification, knowing what it is before it is actually what it is, for sort of an clinical way of saying it, because of this idea that when you reduce how much time somebody is suffering from psychosis, the rates of recovery are much better, and individuals are able to return to their quality of life. And so that's really one of the big pieces of this that resonates with me, and I hope translates to you as well as child providers, is that lots of young people are likely suffering from some of these difficulties, and if we can identify it earlier, connect them to services, the more likely they are to have more successful outcomes in childhood. So with that, some objectives that hopefully will be imparted today. Being able to look at some potential early symptoms. I say potential because there is a very sort of wide range of things that could go on when somebody's having early psychosis. And so, but getting an idea of what some of the key areas are that we're looking for, so then you can investigate a little bit more or talk to somebody about it. Some screening measures. Now, we're going to talk about a few that have been used more often than not. These are based on the research area, and so they're not necessarily clinical measures, but they can be utilized as more of like a qualitative interview. There are some scorings, but they're research scorings, but we're going to go through a few of them, and then that hopefully will give you a jump start to some other areas that you can look. And then the first episode clinic, we have a website, and it will show you at some different points in the slide what the website name is. And there's a lot of resources that we have on there. And in fact, there's a lot of resources on very many first episode programs across the United States. And so we have some links to some of those other resources on there as well, in case you're looking for something closer to your area. So I just wanted to take a pause and have you guys think of these questions, and we'll cycle back to them at the end. And hopefully as we go through the talk, more will come to you for these questions. The first one, when you hear the word psychosis, what comes to mind? Psychosis is sort of, it's a hot word right now. I think it comes up in movies, it comes up in TV shows, and it comes up a lot in the news. And so thinking in your head, what does that mean? In your practice, whether that's schools, hospitals, nursing, private practice, clinics, do you ask about it? Do you ask about it in some way? There's a lot of emphasis now in medical about screening for depression, and lots of talk about self-harm thoughts and suicide, but is asking for things related to psychosis something that is often part of your practice? And then for adolescence is just a rocky time for a lot of folks. And so, you know, some things that look typical may not be, some things that you think aren't typical are typical. And so in your mind, have you ever wondered whether somebody that you've seen, a young person, was this were you attributing that to typical adolescent behavior, or could it be something more serious? So those are the 3 initial reflections. So I will keep moving as you guys think about those. So what we'll do is I'm going to talk a little bit about psychosis, and then we're going to talk a little bit about early psychosis, which is not diagnosable other than an other specified schizophrenia diagnosis. And then what we'll do is I'll walk through some of these early things and give a few examples. And these are prime times also if you have questions to chime in. I'm happy to address questions as they come up so that they're more relevant for you guys. So what is psychosis? So psychosis, as we classically think about it, when we hear the word psychosis, most times it's about hallucinations. Hearing things that maybe other people don't hear, seeing things that other people aren't necessarily seeing around you, smelling things. We have olfactory hallucinations, we've got tactile, like feeling things on your arm, gustatory ones, right? You can taste things that maybe other people don't taste. Those are sort of the ones that when people say psychosis, that they're thinking of most often, that they're hearing or seeing or feeling something that is not there. Another classic piece is this idea of delusions. It's a false belief, believing something that there's no real data or proof to sort of say that there is data or proof that's happening. And sometimes you see this with suspicions of others, feeling that the FBI is out to get you, or the CIA, when there's nothing really that you've done to sort of warrant that, or that some very specific person is there to harm you, and you've never actually met that person, and they are smiling at you, and they're not giving any sort of cues that would make you think that maybe that's actually what's going on in their mind. And then we have some of these, what we call associated features. These are some of the things that I think, depending on the level of your practice or where you practice, you might necessarily utilize or think about often. This neurocognitive impairment, psychosis is very much a brain disease. There's something that is awry in the brain, and I think sort of thinking about it more medically is very important because it helps with screening. It's sort of this emphasis on screening for something that is very medically oriented. And so, things like memory and organization and being able to initiate tasks. When we look at some of the prodromal pieces, you'll start to see some of those early signs that a lot of times at schools, teachers start to notice and show like this slowly decompensation in the neurocognitive domain. Behavioral emotional changes, acting differently than they typically have. And, this is one that really comes to light, I think, when you're thinking of adolescence, because adolescents start to do things differently, right? And maybe hygiene changes. They used to shower and they don't. Well, there's lots of normal teenagers that don't like to shower because they'd rather sleep. But is that, a change from how they used to be? Hanging out by themselves more when they used to be a little more social, changing in how they treat others. Those are a couple of behavioral changes. And then the emotional changes, I think I'm not going to talk about diagnosis today because I'm more interested in the issue of psychosis, but psychosis can go with a lot of different things. It's not just schizophrenia. There's depression, there's things related to bipolar, there's substance-induced, and then there's some very valid medical reasons, seizures and tumors and other things that are very important to consider. But the emotional changes, you do often see some changes in particular anxiety. Seems to be a very early one that children demonstrate because something's changing and they probably are maybe a little bit aware, and that anxiety starts to ramp up. Disordered speech, I think, goes along with the neurocognitive impairment, not making sense and things not really aligning up when they're trying to communicate what they're trying to communicate. And then sleep difficulties, more sleep, less sleep, irregular sleep, sleep that just looks different and isn't helpful. Okay, so that's what psychosis is in a nutshell. So moving on to early prodromal symptoms. I like this quote. This quote was given to me by Steve Adelstein. He's a psychiatrist. He used to be here. He's at Stanford now. And he and Dave Graeber were two psychiatrists who really introduced me into this early first episode domain. And one of the first talks that I saw them both give had this quote in it, and I thought that it really resonated. I'd say I started having paranoid feelings about a year ago. If I really think, things started to happen little by little, but they gradually got worse. I didn't notice because I thought the way I felt was right, and my parents didn't notice because it was so gradual. Mm-hmm. And that gradual is, I think, a very important word because for some folks, it happens right away, right? Like there's a day and then there's the next day and it's like something drastically changed. But usually those aren't the ones that like our clinic or folks get consulted about. It's usually these ones where you're just not sure because something's changing and it's very small and there may be different people that are seeing it. And, I think we have a lot of school providers on here, and I think the school is actually a very important player in this because kids spend more time at school than they do at home, really. And so teachers and school professionals are often the ones to see these changes on a slower basis than parents are sometimes. And so are really important advocates and partners for us in sort of looking at how these things can change slowly, right before our eyes, really. And the gradual part, I think, is also important to emphasize for the impact that it has on a young person's life. When something happens gradually, the number of days that they're suffering with something changing increases. And the fact that if we can look at things earlier, we can maybe help reduce some of that suffering is really why this clinic exists. So what are we talking about? When we talk about prodrome is this term. If you flip back into like the appendices of the DSM-5 now, you'll see something called attenuated psychosis, and prodrome came before that. It's this early signs of something that may or may not become what you think it's going to become, but it's an early sign. And the DSM, when they started researching, there was a big push to sort of put in something about these early symptoms of psychosis instead of, the other specified or unspecified, to sort of call it a very distinct thing. And attenuated psychosis syndrome is the one that they came up with, which is sort of like a weakened version of psychosis, essentially. So you'll see those terms kind of tossed about in the research, both prodrome and attenuated. So what are some of the signs that we are thinking of as we are looking at prodromal psychosis? So deterioration in functioning. Now, I think I put functioning first because I think that the functioning is really the part that is very disruptive to young people and their lives. And so really an emphasis on anything that is disrupting the functioning is interfering with their ability to have friends, to complete academic work, to have relationships with their family, and that part seems to be particularly disruptive to adolescents who are in that developmental phase when they are more social beings and are seeking out independence and trying things out. And so, this deterioration in functioning often is an area that you will see it a little bit more often early. So unexplained decrease in work or school performance. So grades start slipping. Now grades can start slipping for a lot of reasons. And so, you know, but could there be something related to psychosis when you start to look at all of these things together, always as a big picture? Is there something related to the decrease in work and school performance? And, you know, again, the schools are often a very important player in this because, you know, now you can plug in online, right, and you can see all your kids' grades, at least in high school, pretty quickly. And so utilizing tools like that, so let's say, okay, like it's an A, now it's an A minus, now it's a B, and things are slowly going down. And then you start to investigate. You start to look a little bit more about what else is going on in that young person's life that could explain that or not explain that. Decreased concentration and motivation. Another, you know, motivation is a tricky one because you never know what'll motivate somebody. But the concentration piece is a good one. Not being able to focus, seeming to kind of daydream, sort of be off in a way that they weren't before. The change in personal hygiene, you know, it can be something as big as like showering and then not showering, but it could be that, you know, somebody who typically always wore makeup to school and now they're not. And, you know, something is different. Their hair used to be brushed and styled and now it's not. It's very small things that could just start to be a sign that something is different. It could also just be that, you know, maybe they are trying a different style. That's important too. But the thing is that now that it's on your mind, you start to think about what are some of these other things that could be a possible explanation for what's going on. And decreasing the ability to cope with life events and stressors. Adolescence is stressful. There's a lot of life events that happen. And there's a wide range for being able to cope with that. But this would be the example of somebody who previously had some good coping skills and now are unable to actually do that. So change.
It's interesting as you put those up because what comes to mind for me is I see that and I'm like depression. Like I think I would side more on that. So I think you're right, looking at the bigger picture about what else is going on.
Yeah.
Because I see this a lot with my adolescents, but typically it's more depression, and so it makes me think, am I more biased towards just thinking depression sometimes without thinking maybe further?
Absolutely. No, I think that's a really important question just because, I mean, if you look at sort of epidemiologically speaking, it's more likely depression than it is psychosis. But the treatment, you know, would be slightly different. And if you can reduce how much time they are having the psychosis during that depressive episode, then it would be important to sort of highlight it. But I think that that's also a really good public health thing as to think about as well, because we have, as medical providers and, you know, folks who are in the health profession, we get depression. You got to screen for depression. You got to, I mean, everybody screens for depression. You go to any doctor appointment today, they will ask you about depression, right? But nobody asks about psychosis. And I don't know if it's right or wrong to ask about it. I'll be interested in people's perspective, but what's the harm? You know, it's that you ask a kiddo and they're like, if it's not happening, they're like, what do you mean? Or, you know, or you start to, the tricky part is that you start to, again, when you ask that question, it opens a large window. And so you hear about ghosts and you hear about, you know, like you hear about things and you're like, oh, okay, what do I do with that? And with depression, there's a very clear path that you usually you get trained to take. With psychosis, that path I think is a little bit less clear, other than refer to psychiatric. So I don't have the depression and screening process is very interesting to think about, I think, and how this is rolling out as like a public health perspective too. Withdrawing from family and friends, so losing interest in activities. This one there's a lot of overlap, I think, with this and the decrease in functioning. Feeling disconnected, nobody likes me, I don't have any friends. I think I think thinking of like social media is probably like, this is going to change, I think, how we think about, you know, the disconnection and alienation piece. But feeling like nobody in the family loves them, and then that irritability that changes to hostility, where it's like this quick anger towards individuals that are asking them to clean their bedroom or do a chore or take something out. And then the slight increase in paranoia. Now, I mean, paranoia is such a strong word. It probably should be like suspicion, more accurately, but thinking of worries about people that there's no real valid reason to worry. Trauma is an area to sort of, for this one, I think comes up for a lot of folks, like where depression kind of came up for the other one. For you is this idea of like a traumatic event happening. And so, those are some other pieces that are kind of woven through this complication of thinking about prodromal psychosis. But, the suspicious change in like being able to trust people, really, assuming they were already sort of trustful. Changes in behavior, thoughts, and emotions. And the prodromal sign really emphasizes the fact that they're still able to have some insight, which means that they are aware that something is different and they can talk about it as such, but something is changing. Fears, they're starting to maybe have some unusual, I thought I heard somebody call my name, but I turned around and nobody was there. We all have that. And we all have, there's a trajectory, where we've like, thought I heard somebody knock on the door and I opened the door and nobody was there. But you start to, when you talk with a young person, you start to, again, you're putting together this picture, you're painting this picture, and you're starting to see there's been more and more instances of that actually happening. Ghosts, unusual experiences in that. And, that's a tricky one. There's lots of sort of cultural and spiritual beliefs around ghosts, but you're putting an ear to it. So you're starting to sort of see like what's going on in the family. Does the family have the same beliefs? Magical thinking that they can do things that aren't typically able to do. Disorganized speech, unusual behaviors, not being responsive. So this is that last one, reduced emotional social responsiveness is, I think a lot of times when you're doing something like a mental status exam, you're trying to see like what is the quality of their affect. And this prodromal sign is sort of saying that you're starting to see some more of that flatness where they're not showing a wide range of happiness, sadness, anger. Things are just kind of right in the middle, and you can't quite tell what somebody's feeling. So starting to see a little bit of that in this prodromal phase as well. Sensory experiences, heightened perceptual sensitivity. And this one, the second bullet there, the loss of brain filtering. There's this image I remember that Steve Adelsheim would always put up, and I couldn't find it, but I think it's a really valid one. If you think about like, it's like if you can I'll paint the picture for you in your head. So you've got this image of like a drawing of a person sitting at a table. And if you imagine a piece of paper that is sitting in front as an invisible sort of filter. And as you go through the day, you are constantly getting stimuli, and your brain is basically this filter. It's sending all of this stuff through, and it's saying, okay, there's a fan on, your brain sort of filters it so that you can still attend to what's going on. There's a car beeping, there's a dog talking, there's somebody whispering, there's somebody clicking their pen. Your brain is filtering that, and you're able to then continue what you're doing. You can function. With psychosis and with early psychosis, this filter is wholly or it's gone. And so all of that stuff is coming through, and you can't attend to any one thing. So your fan's coming and you're turning around, you're like, where's the clock is ticking, and then somebody's beeping, and their attention is all over because this filter is faulty, and they aren't able to really use their brain in that way. And so with prodromal, you might start to see some of the early signs of that, where that filter is kind of weakening and disappearing, and they do maybe look a little restless because they are kind of heightened to all the sounds that are around them. They may be jumpy, they may startle, there may be lots of behavioral things that you see. And then it coincides also with the decrease in academic and work functioning. If you imagine that you're at work all day and that filter's gone, there's no way you're going to be able to sit there and listen to the teacher lecture or to do a homework assignment. And so, again, as you're painting this picture, you're connecting these things. You're like, okay, well, maybe that filter is weakening, and that's what's going on with the grades, because there's no other, we can't think of any other explanation. And then that anxiety increases if you're being bombarded by lots of stimuli that you previously were able to filter. That stress on your system, it will create a feeling of heightened anxiety. And then being overwhelmed by things like the last straw will happen a lot faster, and not being able to sort of your kid is at school all day and then they come home and you say, how was your day? And it's like, whoa, okay. That's that buildup of stress that can go on throughout a day as they're struggling with things. Again, could it be lots of things? Yes. But why not think about some of these other things that could be related to psychosis as well in the back of your mind? Magical thinking, sense that things aren't real. I'm trying to think, this one comes of a good example of this. The grandiose ideas probably is the big one, is sort of this idea that they are really good at something and you don't have any real data from other people to suggest that that's actually true. And then the feeling that things aren't real, that they're just sort of floating through. Sometimes you'll see that they're watching their day go through. They seem kind of dazed. And then along with that, some of the ideas that they will start to sort of talk about might just seem unusual than what they previously were talking about. And there's no sort of reason for that. I don't know if anybody else has any good examples of that one.
We had an exchange student who did this at our house, and we, called his parents and sent him home.
Okay.
And it turns out that later on, this turned into one of these episodes.
Oh, interesting.
And he got treated. He's doing fine now. He's an adult. Has kids.
Yeah.
But it was all about, he'd been in South America and was traveling through, so like a summer exchange student, so he wasn't spending very much time with us. But he started talking about knowing how to do all kinds of things with physics, and then he understood Einstein's theory. And my husband's an engineer, so it was things he was saying. It was very odd. We just thought, okay, you're young, you're going to school, you're really smart. Maybe you learned something when you were in Central America that that's different. But when he went back home, it progressively got worse. But we didn't recognize it for what it was until a few months later, when the parents called and said we had to admit him to the hospital because he just literally fell apart. He went nuts on him. Is basically what they said. Basically what they said. But that was an example of we didn't know what to do with that. Like, well, okay.
I know, you're right. And you're trying to be supportive. You're like, okay, this is great. You're going to be a scientist. But then you're like, okay, what is around? And I think that also goes with that childlike piece, but it's sometimes you'll see them sort of say oh yeah, I know how to make an airplane. You're like, okay, that's great. You're going to be an engineer, but when does it sort of cross that line? And it is sort of, it is tricky, especially unless you sort of think about all the other things that were going on. That's a great example. Thank you. Unusual perceptual experiences. I think this is often the one, again, going back to that classic psychosis that people think of the most, and I think is often the part that people look for the most, which I think is maybe part of the difficulty in sort of shifting and screening. But the shadows, the ghosts, the odd sounds, hearing your name called, and then occasionally some of those feelings throughout the body, usually experienced as on the arms and sort of the extremities, feeling like your arms falling asleep. I've heard that one quite a bit.
This is where people talk about spiders and that kind of thing.
Yeah, the spiders, or somebody's tickling. Unusual fears. So we're unable to trust people that they previously were able to trust, and there's no sort of valid reason, no trauma or any other reason to sort of think that they shouldn't be able to trust that person. Again, the paranoia comes up here, the fear, the suspicion that others are trying to hurt them. The fear, I think, with the mind reading, I think it's interesting to think about with the isolation and pulling away. And so, this idea that if you get close to someone, the more likely they are to read your mind. So if you think about this idea that folks might be isolating themselves because maybe they're worried that somebody is reading their mind, or that sort of feeling of anxiety that they have that, whenever they're talking to somebody, that their thoughts are being sort of accessed. And this one, I think, is, the trauma comes up in this area as well as sort of an area that you're fishing things out, as well as sort of anxiety, the social anxiety. Disorganized speech and thoughts. Maybe, I think there was one example I had where, a teacher sent a referral, I think probably to a school counselor, and the referral included something along the lines of their papers were unintelligible. Like they previously were able to write paragraphs, but they submitted like a clip in it, and the flow wasn't there. There was no punctuation. They previously were good students. It wasn't necessarily an ongoing sort of learning disability. And so, again, highlighting the important role of school is this idea that in written speech, that the disorganization can start to appear. Families and friends starting to say, like, you're not making any sense. Like, I don't understand, or you're trying to ask questions and they're unable to sort of give you a valid or reframe things in a way that makes sense to individuals. Talking about things that are off topic. You ask them one thing, they talk about something else entirely different. The racing speech, I think that you can see that. And then the over elaborate speech is an interesting one. Sort of the talking, and they weren't previously that much of a talker. And again, you're seeing this in the picture of everything, but oftentimes I think with that heightened anxiety, you'll see sort of some of those excessive talking things as well. And I think when we're thinking about sort of this idea of sort of figuring out this versus that, I think since we sort of talked about depression and we talked a little bit about trauma, the substance-induced or substance use sort of comes up in my mind, and for this area, when you sort of start to say, okay, like, I think people will say, is he high or is she high on something when they start to see some of these things. And so, and again, our minds, because we've been trained as providers, we go to depression, we go to trauma, we go to substance. But what about psychosis? What is it that could be underlying some of those things or be more of a contributing factor? So kind of adding that to like an immediate place that our mind could potentially go. Uncharacteristic peculiar behavior, and this is a little repetitive here as well, the change in hygiene. The new interest in religion is interesting. And it's actually interesting, there's a book out there, and I can't remember the name of it, that really talks about like this idea of sort of the social constructs of psychosis, really. And religion, in the past has been, I think, an important one, but now technology, I think, is probably an interesting one to think about with peculiar behavior, with this idea that smartphones are, being utilized to spy, or, new interest in the ability of technology to sort of control things. So I think that adding that to the peculiar behavior probably is important these days. And then a change in peer group, risky behaviors that are different, wearing long sleeves, a beanie, and a winter coat when it's 80 degrees outside, or coming into your winter session with a tank top. And I mean, that's a tricky one because lots of adolescents don't need jackets, right? But, this idea that they are dressing differently and probably not appropriately for the weather. Reduced emotional social responsiveness. So you start to see some of the depression, the lack of energy, the lack of speech, some of the memory difficulties, having a hard time remembering what you asked them to do or remembering what they were supposed to do at school, being distracted, irritability. And then it is, important to ask about the suicide and suicide attempts as well. And reason being because of this increased level of anxiety that a young person might experience during this period. That anxiety is often really, in many ways, a higher risk than sort of low mood for suicidal behavior, wanting to get rid of it immediately. So we've talked a little bit about psychosis, and then we've talked about some areas for prodrome psychosis, some early things to look at. And so this is just a slide to sort of say that there is a wide spectrum of these difficulties, and at any given time when you're meeting with someone, you're kind of moving the ticker along the trajectory. Now, these are just 3 examples, but if you think about all of those different things that we talked about, they all have a trajectory. Like I mentioned, we all have those moments when we think we hear somebody call our name, but nobody was there. And that's at the very low end of the trajectory. I think that it's a very common experience. Now, then on the higher end is that you are having conversations with somebody and you're hearing a voice and you're talking to that person, and everybody is aware that there's nobody actually there. They're on the same continuum. And, for different individuals, where that is disruptive is going to be different. For somebody thinking they heard their voice called, oftentimes we just sort of play that off. But the closer it gets to the far right of the trajectory, the more disruptive it is to functioning, the more anxiety inducing it is, and the more likely it is that some sort of intervention is needed to help. And so this just gives an example of okay, if somebody's grandiose, a light example would be okay, they're really good at basketball and they think they'll go to college and play. On the far end being, okay, they are maybe ready, they're 12 and they're gonna go try out for the Knicks. Or is that the team still? the team. And so they're gonna go try out. So, sort of a little bit of a childlike logic and a little bit of a delusion there. And so you can see the other examples there. This is an illustration of that. The spectrum of risk is really important to sort of think about when we're looking at this idea of reducing the duration of untreated psychosis and catching people. Do we want to catch people in the drop in functioning withdrawal, or do we want to catch people in the full psychosis? Right now, most people are caught in the full psychosis because they're presenting to a psychiatric facility, or they're presenting to an emergency room, or they're being picked up by police for something related to their psychosis and then brought to the hospital. And that's good, right? We want to catch people who are in full psychosis, and that's important. But the research that is looking at that is really saying that some of those folks who maybe are in a first episode of full psychosis have had the average, I believe, is 74 weeks of untreated psychosis. So that drop in functioning withdrawal, that they've been living with that psychosis. So it's a really long time. The duration of untreated psychosis in sort of the research field is defined as the time from first symptoms to the time of first antipsychotic. There's some wiggle room around whether or not it's first dose of treatment of any kind, whether that's an antipsychotic or not. But the original definition is the time from first symptom to actual prescription and taking of an antipsychotic to reduce those psychosis symptoms. So the prodrome work, the work that was being done, probably in the past 10, 15 years, really focused on that drop in functioning. And, I think that there was a little bit of pushback that maybe that was too early. So then thinking about this idea of the attenuated positive symptoms, getting closer to that area of full psychosis, but it was more clear that it was going to be psychosis and maybe not something else seemed to resonate a little bit more. And I think that that's where we see a lot of the research coming out. And then the emphasis really on how important it is to catch full first symptoms of psychosis. And this is just a slide that talks a little bit about what I just mentioned, the duration of untreated psychosis, how it's defined. The longer that somebody is untreated, naturally, the more impacted it is on their quality of life. And then the harder it is for your brain to really recover. So what do you do to find this? And so there's 3 measures. There's 2 measures that are here, and I believe that they're downloadable for you all if you can't read them on the screen. Is that right?
Right. They're available on our website where you registered on our calendar.
Perfect.
So I'll go ahead and send it.
Perfect. And these are all measures that you can find online. they all are based on what's called a SIPS and a SOPS. It's a structured interview for prodromal psychotic symptoms. We'll come to the exact definition of it. And they are, again, research measures. When I use them in clinic capacity, I use them as a qualitative interview. I use them to gather data. There is a scoring for it, and it's more of an ultra high risk versus a high risk. And there's some wiggle room. You can use it for like making sure you catch more people, but there may be more false positives, people who really don't actually have what you're looking for. Or you can have a lower threshold, but then you might meet some people who really do have criteria. But that's the type of measure these are. There's not like if you're a 10 and higher, that's clinical, and 10 and lower is non-clinical, just so you have that off the front. And, you know, the biggest measure that is the last one that I'll show you really is probably the gold standard, but nobody has the time to do a structured clinical interview every single time. But it's a good measure for you to go and take a peek at, so you can get an idea of just for the informal type of questioning that you can ask to get at some of these symptoms of psychosis. The PRIME screen is the one that is the briefest. It's 12 questions. And what you do is you read. Now, theoretically, you can hand this to somebody and they can do it on their own. I think with adolescents, that's not a good idea. These measures were mostly created for 18 and older. So I think if you're going to use it, the PRIME screen is more one that you would want to sit down and talk through with somebody to make sure they were understanding what they were being asked. And also the types of examples met your sort of clinical threshold for what they were looking at. And it still goes quickly, but it does add some time to whatever sort of clinical interaction you're having. I think that I have felt that there are odd or unusual things going on that I can't explain. Now, you get a wide variety. You need to get examples. There's a scale. They can say how much they agree and how much they disagree. But the way that I think if you're going to use this clinically, it's important to get very concrete examples for what they're saying, so that then you can put them together and it helps you kind of paint the picture for what different things could be going on for them. So I'm not going to read all the questions just in the nature of time, but that's the PRIME screen. This is also downloadable on the website, as Kevin said, and this shows you a little bit about the scoring and the administration. It clarifies that it was created as a research instrument, and then talks a little bit about the criteria for it and where it came from. The PQB is the Prodrome Questionnaire Brief. It's basically a step up from the PRIME screen. They're created again from the same structured interview. And this one there's a few versions floating out there on the web, 21 version to 24 version, and I think this version might have 25. The difference between this and the PRIME screen is that you are really interested in how much is this creating a problem. Similar sorts of questions, so just differently surrounding sometimes seems strange. Yes, okay, well, how distressing is that to you? And getting an example of like, okay, well, when this happens, it doesn't bother me at all. Because again, if you're thinking of the role of diagnosis and the role of treatment, it's really how is this impacting their functioning, or is somebody else seeing this as impacting their functioning? And so you can take a peek at these ones, and this is the 25 version one. There is an important caveat, I think, with the PRIME screen, and particularly with this one, is that when these measures were created, they asked that they weren't experiencing these symptoms during the course of substance use. Now, that's a tricky one, I think, because we get lots of referrals, and probably 95% of them have substance use. And so you may miss some people if you think that it's all substance abuse and not necessarily psychosis. So I think just sort of use some clinical judgment, or consult with somebody if you're not sure after asking a question. This is also downloadable for you. I'm not going to go over it, but just so you can see it, it's a document that, similar to the PRIME, tells you a little bit about the scoring and how to maximize and minimize sensitivity and specificity. Actually, maximize both of them. You don't want to minimize it. Okay, so these were all built on the structured interview for psychosis risk syndromes. This was a big measure that was utilized in some of these early prodromal studies to rule out past and current psychosis, look at lifetime history, determine the current status of each psychosis, whether like where is it present, or is it in the lifetime, early on, current, and then the severity of it. And this is a very, and it's a long structured interview, but it gives you some really good data. So I think it's important for you to look at it and to just familiarize yourself if you're not going to use it with the language, because it just gives you some language to use. Just like, people are like, I don't know how to ask about suicide. And then we got all this training about how to ask about suicide. Well, this is similar. Like, this is how do you ask about psychosis? You don't necessarily just have to ask about seeing or hearing things. There's all these different subtleties that are important to know some language for. And that's what I think in a clinical context, the SIPs can be very useful for. If you have the time to administer it, though, it will give you some very useful data. So if you suspect psychosis, what can you do? Now, the bottom here, this is the earlyprogram.org. That's our webpage, and the number 188 New Mexico Early is our referral number. And if you are not in New Mexico, there are some, Oregon has a site, it's ESA, actually one of the first sites. They've been doing this for a long time. And I don't know if Puerto Rico has one, they might, but every state at this point has a first episode clinic in some capacity. What happened was there's these state block grants and that were given through the government, the federal governments to states, and 5% to 10% of the dollars were earmarked for first episode psychosis. And so every state should theoretically have one. Puerto Rico probably the closest one would be one in Florida. And so there should be resources available in every location. There's different models. Each site may use a different model. We utilize here in New Mexico the RAISE model, which is a coordinated specialty care, which means that we provide a variety of elements that they have found through these recovery. RAISE is a big NIH study called Recovery After Initial Schizophrenia Episode. That really was like the big thing to sort of say, like, how do we work with individuals with psychosis, with schizophrenia in particular, and what's best practice, and can people do it in the sort of standard practice. And the idea being that you look at psychiatric care with medication as needed, a form of therapy which would be more like skills-based, focus on recovery and goals and how to get back in functioning, supportive education, case management here, comprehensive community support services, and a large amount of work around family education, lots of family support, helping understand the diagnosis, how to reduce stress in the house, what do we do for relapse prevention planning. And so a lot of these models utilize a similar process. Our clinic works for 15 to 30. A lot of folks do a similar age range just because that's sort of the sweet spot that catches folks when first episode of psychosis is most likely to happen. And most models, if not all of them, are now recovery oriented. The idea is that recovery is possible. The previous model is that, chronic psychosis, you're going to have this forever, and there wasn't very much hope. This idea that you're catching it earlier, catching it at any point, that recovery is possible, and that may be different, but your recovery will happen with whatever goals it is that you set for yourself, whether that's going back to school, going back to work, having a family, being able to open a business, whatever it is. And so that's part of the treatment model from the beginning. And then this is just the information to access the webpage as well. And so the last piece is just the final questions. I think as you go about your day and you practice thinking about what it is that you think about with psychosis now, do you ask about it? And, thinking about, is this typical or is this something that could be more? And with that, questions?
Yeah, those are some great reflections. So please feel free to voice your questions either over audio or in the chat box. This is an excellent overview, though, of what to look for. And it was interesting looking at the screeners because I could see what I hear a lot with doctors or those that aren't very behaviorally savvy, or at least they tell me, is that even with the depression screen, I get this.
Yeah.
Like, we don't even want to ask the 2 depression screening questions.
I know.
And I can imagine what comes to mind when
like, oh my gosh.
yeah, the prime or one of those others. And so I just wonder, do you ever run into that?
I think that yes. I think that that's interesting, though, thinking about the bigger push on integrated health. And if a clinic has a provider that they can easily access, then they're more likely to do it. In the RAISE model, if we were to do it the purest way, we would have primary care in our clinic. And so that or we would be in primary care, or vice versa, right. So that if a primary care doctor or pediatrician asks this question, then they can immediately get somebody who can come and address it. Now, a lot of places have consult services, but there's usually 1 or 2 consult people for the whole system. And so I think that there's some hesitation there. And so I think it really makes a really good case for like this improvement of having a behavioral health provider in a medical setting and in school-based clinics, and being able to sort of utilize a multidisciplinary model would help screening and people's comfort.
Absolutely. Great presentation, right? That came up. So any questions or comments from this group while we let people chat in? Pediatricians.
One more thing you have to screen for. Developmental screening, emotional development now. Right?
I know, right? The ages and stages.
Yeah.
I think it's helpful to just know what resources are out there, though.
Yeah.
It's not something we're exposed to a lot in training, so.
Absolutely.
Yeah, just if something is triggered in our mind, to be able to go look at those prime questions and at least like kind of remember things to ask and where to go from.
Absolutely. I mean, I think that's important too, because before even sort of coming up with like a protocol for screening, like you don't have to ask if you start to think about these things and you'd be like, you know what, I feel like this is based on this and this, like, and then you can make referrals, right? And referrals are just referrals and recommendations, but at least you can know where to sort of guide people.
A last question for me, and then we have a question.
Elementary school.
Yeah, in fact, let's go there. Yeah. So the question is, or the comment is, the handouts seem to be addressing the 15 and older. What about elementary school children?
So, psychosis in elementary age school children is possible, right? It's rare, but we get lots of referrals for that, usually because of wanting to know whether this is autism or psychosis. And so, I've been looking a lot in that myself, just because we seem to, I think with the increase in screening for autism, with people being weeded out as not having autism, they're like, well, what is it? And so we're sort of seeing like a rebound effect of like, what is it? What is it? Is this psychosis? It's a very sensitive area, because if somebody is flagged as having psychosis and you give them a referral to psychiatric, they're going to put them in an antipsychotic. And obviously there's lots of concern of antipsychotic use in children, and let alone elementary age children. And so I think that, when I have an elementary kiddo who comes to me and there's a question of psychosis, I go over something like the PRIME screen in a clinical interview, and I gather the data. And then you're really looking for the impact on functioning, and you have to get lots of multiple reporters if possible. You need a parent and a teacher or somebody to also say that they're seeing these things outside of the session, outside of just one location. And then you're just really trying to see, could this be more likely explained by something else? And so you're doing lots of ruling out. Is this depression mostly? And is this someone who is utilizing things to get something getting a need met? Or is this psychosis, right? I mean, I think it's important to think about it with young children, with the caveat that it's rare. There's a measure called the CUB scale I did not talk about. It's capital CUB, and then I think it's just scale. and it stands for something that I'm not going to remember. And there are some questions on there. It's like a true false measure, and it's a research-like measure. You'll probably be able to find it as an article with the measure attached. I can look for it, and if I can find it, I think I have a copy, and I can send it to you guys, and you can send it out. Tends to be a little bit easier for children to understand, elementary school children, and you can use that to sort of get some questioning going to sort of see what might be going on. But yeah, it's tricky with the young kiddos because it does send people down a little bit of a treatment path, and it's like, psychiatry doesn't have much time with patients, and so they see that and they're gonna go, and so you want to make sure that if you're sure if that's what's going on, you put that in there. Mm-hmm.
Excellent presentation. Yeah. Thank you so much. No problem. And thanks to everyone for tuning in. For those of you who participated in the AHI and are interested in certification certificates, then I will be in touch with everyone to make sure that we have everything on board for all your requirements. And it's been a great AHI season this spring, so thank you for everyone. And there's a lot of just great presentations. Thank you for the presentation. And Sandra just said, I really appreciated your demonstration of how psychotic symptoms exist on a spectrum. It's more complex than I learned in training. So I agree, Sandra, definitely it's a helpful way of thinking about it. So thanks, everyone.
Yeah. Thank you.
And if everyone can hang on, I will be posting the link to our post-session survey. I will go ahead and mute here momentarily, but if you wouldn't mind just taking a few minutes to go ahead and fill that out for us, it does help us improve our programs.
Absolutely.
So thanks again.
Everyone have a happy Easter. We'll be in touch soon.